So today we are going to discuss pseudophakic refraction part 2, and in which I have taken few examples of pseudophakic refraction and what points should be keep in mind to perform this pseudophakic subjective testing. And before going into the next slide, let's summarize the previous session in which we have discussed that most important thing in unaided visual acuity in pseudophakic refraction. So you have to note down that what is the unaided visual acuity of the each individual eye, right and left. Then decide spherical equivalent first, that which side of whether it is myopic or hyperopic refraction, that the patient will guide you for the same as you put the plus or the minus lenses on either side. Then you have to define the axis with the stenopic slit. You have to put a stenopic slit and rotate it in the trial frame, and patient will give you the idea that at which axis the vision is more clear, and with that you have to keep a slightly larger image on the Sneller's charts. I mean to say, you have to put either 660 or 636 larger letters on the Sneller's chart. That will give more idea to the patient about accuracy of the result. Then define cylinder at that particular axis which is suggested by stenopic slit, and then you have to try different combinations of spherical and cylindrical power, and this combination along with the nearby combination of the nearby spherical equivalent. So these points we have discussed in our last session. Now today we are going to see few of the examples. Let's start it one by one. Before going in individual cases, tips for pseudophakic subjective testing. The first point, if age is 60 plus, no need to go for 6 by 6 vision, settle on 6 by 9. If patient fluently reads 6 by 9 letter, then and then only you can try 6 by 6. Otherwise, if patient is reading 6 by 9 hesitantly, don't show 6 by 6 to the patient, because most of the time there are many reasons which can compromise the visual acuity by one line, just like age-related macular degeneration or some macular pathology or some posterior capsular opacification or some corneal opacity or some media opacity or floaters. Anything can reduce the vision by one line physiologically. That is an senile change or age-related degenerative changes. Then you have to check the vision on red green. The brightness and the clarity on red green should be equal or nearby. If patient is not getting equal clarity on red and green, then you have to go for red clear. Pinpoint pupil will give better visual acuity. Suppose a patient with having a 2 diopter myopia, in one patient, if the pupil size is 2 millimeter, and if another patient which has pupil size of 4 millimeter, the smaller pupil will be corrected with less amount of power. That is, he might be corrected with 1.25 diopter also. So the pupil has its own power. So that you have to keep in mind whenever you start your pseudophakic refraction. You have to apply torch on the eye and check whether the pupil is smaller in size or larger in size. So in smaller size pupil, the pupil has its own power, just like a pinhole. As we say that pinhole can correct a certain amount of spherical or cylindrical refractive error, and it improves the vision by pinhole. Give minimum power for maximum vision. Near addition should be checked monocularly, as two eyes might have a different near addition. This may be because of different kind of IOL implanted. There are chances that patient might have a multifocal IOL. So after making distant correction, you might not require any near addition, and patient straight away will go for N8 or N6 without any addition. Mini fogging needed sometimes to get the accurate spherical for correction due to higher order spherical aberrations of the IOL. Sometimes there are implantation of a aberration correcting IOL or negative aberration IOL. So this will sometimes demands mini fogging. What do you mean by mini fogging? You might have to, if suppose patient has +1 error, you might have to start with +3 and then gradually reduce to +1 to get the accurate spherical power in that particular eye. But you have to take certain cautions also while performing pseudophakic refraction. If the pupil is eccentric, be cautious that patient will not give 100% accurate result and patient will not achieve 6 by 6. If auto refraction cylinder and axis is not matching with auto keratometry cylinder and axis, then you have to keep caution. If IOL is decentered and tilted, this is another caution sign while doing pseudophakic refraction. If dry eye disease is associated, then also it will not give best visual acuity, that is 6.6 or 6.9 or 6.6 partial. If there is any retinal pathology, posterior capsular opacification, media opacity, this will also hamper the visual acuity. And the most important, intraocular pressure should be normal when you give final postoperative refraction 40 days after surgery. So these are the important points. The suture removal can change the refractive error. So don't give the refraction on the removal of suture on the same day. You might have to wait for 15 days or so after removing the sutures. So these are the points you have to keep in mind, especially when you are doing pseudophakic refraction in post-operative cases. You have to check the file of the ophthalmologist, the notes of the ophthalmologist. If the ophthalmologist has written very nicely everything, there should be some tilt or some decentration or the pupillary decentration. It is there or not, and that will decide the final outcome of the subjective testing and the final visual best corrected visual acuity. So let's jump to certain clinical cases which will give you idea that what is the existing clinical situation and what refraction you achieve. So this is the first case. In this case, both high spherical lens implanted instead of aspheric, depending upon the personal choice of the patient and his financial condition. So you can see on the left, that is in his right eye, there is a mild drooping of the lid. This eye was operated 5 years back, while the left eye operated just 1.5 months back. Now you can see the right eye has adjusted and the lid position has come down to correct certain amount of refractive error, and that will give a good clarity of vision in that particular eye. So patient is try to adjust it. Now you can see the right eye visual acuity unaided is 6.9 blur while left eye is 6.6, and you can see the binocular visual acuity is 6.6 and binocular near vision is N8 and N6 partial. So what it means, the right eye is obviously myopic, then and then only he or she can get good near vision. So depending upon this situation, you can judge that you have to give certain myopic refraction in your right eye. So let's see the final refraction of this patient. This is the AR and the AK reading. You can see both the eye have minor cylinder. On keratometry, it is 0.5 diopter cylinder at some odd axis of 39 and 34. While in refraction, it is almost similar 0.75, and the axis is not matching with the keratometry. It is 65 and 60, while the on the other side is 39 and 34. So the axis of these two are not matching, so it will not give you clear cut idea. So here as the left eye has 6/6 vision, you don't have to do anything. Okay, so in right eye, you have a minor spherical, which is not much, just 0.12. So you consider it is as a pure astigmatic error. So you just put a stenopic slit to decide the patient's final visual axis, and on rotating axis patient will give you idea that one axis is perfectly in focus and that will be corrected, and that is the axis of your minor cylinder. So in this patient, the finally patient has accepted minus 0.75 diopter cylinder at 65 degree, and that is the axis is matching with the refraction on autoref, and that is your final refraction for distant. And for near addition there is a +2 addition requirement because of the spherical IOL implanted in the both eyes are same. So that is the first case. Any query regarding this first question, first case? Any question regarding this?
No, sir.
Not. We will move to the second case. Okay, this is the minor refractive error, so it was not bothersome. Now we are moving to the second case. In this, I don't have any clinical picture, but in right eye, the vision is 6/9 partial, and in left eye, the vision is 6/12, and the binocular vision is 6/9, and the near vision is an 8. The near good vision is suggestive of one or both of the eyes are having myopic refractive error. So it is getting tallied here that in right eye it is a minus cylinder, and in left eye it's minus spherocylinder, if you can see on the autorefractometer. But still the keratometry reading are not matching with the amount of cylinder on the autoref. It is 0.87 at 61 degree, while in the left eye it's 0.5 at 83 degrees. So the axis is not matching. So for this, the axis in right eye especially, the one axis is in focus, it is 0, 0. So stenopic slit straight away give you the axis if you put some larger letters like 660 or 636 and move a stenopic slit to get the accurate cylinder, accurate axis, and then you decide the power by subjective testing and bracketing of the amount of the cylinder in right eye. So that is right eye. While in left eye, you need some sort of spherical first or spherocylinder for the correction. So in this also, as the keratometry is giving 0.5 cylinder only, this cylinder may not be required, or only 0.5 or 0.75 less cylinder may be enough to correct the refractive error. So in left eye, the combination of spherocylinder must be needed. Let's see the final outcome. So in right eye, the AR reading is the on the right top. You can see the right eye is corrected with 1.25 diopter cylinder at 70 degree. And as I have told you, patient is reading one letter less in final 6/6 line in both the eyes. And in the left eye, zero point 0.5 cylinder with 0.75 cylinder at 65 degree. Here also the same, one letter less. Patient is not able to read one letter in last line. And the most important thing is intraocular pressure should be normal when you give final subjective refraction. So it is 12 and 10. The normal range of intraocular pressure is 10 to 20 millimeter of Hg in non-contact tonometry. And in Goldman supplanation tonometry, you can be safe up to 22 mm of Hg, depending upon the optic disc cupping and the other status of the eye. So that is the most important point. If your IOP is high, you will not give final refraction. If your IOP is normal, you can give the final refraction. So this is case number 2. Now let's see the some odd cases. Like this patient was operated for a corneal tear first in right eye about 4 months back, and about 2 months back, patient developed cataract. uh, as you can see, there are the scar of the corneal tear is visible in the uh, illustrated figure, while this is an autoref figure in which you can see there is a trauma to the sphincter muscles also at 5 o'clock position. So these are matching with each other, and in this case, because the foreign body has penetrated from the cornea, injured sphincter of the pupil at 5 o'clock position, and it has entered and tear the anterior capsule, the posterior capsule, and reached up to the retina. So this was a big foreign body which has entered into the eye, and somebody has done surgery for corneal tear repair with foreign body removal about 4 months back. Now, after that, about 2 months back, I have operated this patient, and as there is a rupture of anterior and posterior capsule, I could not able to implant the intraocular lens in the bag. So I have put the lens in the sulcus, three-piece intraocular lens in the sulcus, that is between the anterior capsule and the iris. So here the normal physiology is disturbed. There is a mild decentration also because of structural support is weak. So in this case, I have put all the data on this figure. You can see the other eye is phakic eye and normal eye. So in right eye, the patient has 660 vision after surgery, while in left eye, patient has 66 vision. Left eye is having N6 vision because it is a phakic eye and patient is 40 years of age. And in right eye, patient has minus 2.12 diopter of reading for distance, minus 2.12 diopter autoref reading for distance. So it means that patient has approximately minus 2 refractive error myopic, which will give him good vision for near. And if you can see, no cylindrical power. Cylinder is visible on keratometry, that is 0.87 diopter at 95, which is also not so much significant. His intraocular pressure in right eye is also normal 18.3, in left eye 14.7. So the final refraction in right eye was minus 2.25 for distance, that will give him 6.6 vision, while in left eye the 0.5 diopter cylinder at 35 degree will give him 6.6, but it is not required to give, as patient is having unaided 6.6 visual acuity. You can avoid this minor refractive error because sometimes patient's brain has adapted this 0.5 diopter of cylinder at 35 degree. It is called neuroadaptation, and if you give over it, patient might have some eye strain. So lesser cylinder of 0.25 or zero point 0.5 can be avoided in final refraction. And in near vision, right eye has plus 2 addition, while left eye has plus 1 addition, as his age is 40 or 41. So this is in case of that is why I have told you that you have to do monoocular near addition, that will decide the final spectacle power. Patient will have right eye plus 2 because of pseudophakia, and left eye plus 1 addition due to presbyopia. Let's see one more case. So this patient was given the final refraction like this. One more case, case number 4. The patient is having unaided visual acuity of 6.6. No complaints in on autoref. There is a 0.75 cylinder at 50 degree. Patient has no cylinder on keratometry. The near addition is plus 2.25 diopter spherical and gives N6. His intraocular pressure is 11.7 in left eye, which is operated. So everything is fine. you can see, you put all this together and you finally decide that everything is fine, then go ahead with the final refraction. That should be around 1 month after surgery, not before that, because intraocular pressure can be variable with use of steroid and non-steroidal anti-inflammatory drugs. Even the healing of corneal incisions may change refractive error over a period of time. So don't be in hurry to give refraction. Explain patient that the power will change 30 to 40 days after surgery. So better we will give final refraction 40 days after surgery. So don't be in hurry. Or even if patient is working on computer, then after a week of surgery you can ask patient to make a temporary glass to work on computer. Let's see another case. This is case number 5. You can see both the pupils are round and regular. These photographs are not taken simultaneously, so you might feel that left eye has some exotropia and right eye has some hypertropia, but it is not so. Patient has both eye orthophoria, but individual eye photo is taken and then merged on this slide, so it is not so. So this patient was having operated on March 2021, just about 1.5 to 2 months back. So this patient, you can see I have written all the criterias for refraction parameters of biometry here, and the IOL implanted sticker is also applied here. So this patient has 0.5 diopter cylinder at 90 degree in right eye on keratometry, while in left eye it was 1.13 diopter cylinder at 96 degree. So for left eye, there is some astigmatism is there, and for that, I have done limbal relaxing incision to correct this amount of astigmatism. Limbal relaxing incision can usually correct 0.5 diopter to 0.75 diopter of astigmatism if you do properly at proper axis. So the plan was to implanted lens are 23.5 diopter and 24 diopter in this patient with left eye LRI was done. So now let's put all the investigation and clinical assessment points on one page. So you will take unaided visual acuity first, that is 6.9 in right eye and 6.9 partial in left eye, and binocularly patient is reading 6.9. So in this patient right eye, uh, the both the eye error is simply cylindrical power, there is no spherical. So in this kind of patient, there is one axis which is emmetropic, while the other axis which is myopic. And these kind of patients are very happy binocularly, because most of the time this kind of patient has distant 6.9 vision and near almost N8 vision. It is not mentioned here, but this kind of patient is achieving almost N8 vision without any addition of glasses. So binocularly unaided vision of the patient is 6.9 and N8. Now you can see the keratometry is also showing 0.75 diopter cylinder at 87. In left eye we have done limbal relaxing incision, so the astigmatism has come down from 1.13 to 0.38. Rather it has corrected over because it is going on the opposite side of the axis. That is because it is an giving 0.38 cylinder at 18 degree, which is almost right angle to 96. So the correction of the cylinder is 1.13. Say it has corrected to 0.38 at 18, almost 1.5 diopter cylinder is corrected with the limbal relaxing incision. And this is, I mean to say, this is overcorrected. In senile patient, the limbal relaxing incision will give high effect, or some young patient will give less effect because the tissues are more elastic and flexible. So LRI will give less effect in younger patient and more effect in older patient. But this will regress over a period of time also, because as there is a scarring and contraction, the effect of LRI reduces with time and changes with time. But ultimately the patient will be very happy with minor cylinder only at particular axis, because one axis is almost immetropic, and the near addition is 2.5, which gives N6 result. And you can see the intraocular pressure is also normal, 14.3 and 16.3 in both the eyes, so the final refraction can be given. Now case number 6, when the patient come to you, see this is the patient which has both eye toric IOL implantation. So when patient come to you, if patient will not bring any file with him, you will not able to know that whether the patient is implanted with toric IOL or whether patient is implanted with monofocal or spherical IOL or aspheric IOL. So here the both the things are important. I have selected this case for toric purpose only. Similarly, multifocal cases can also come to you. In that patient also, unaided visual acuity monocular and binocular, and unaided near visual acuity binocular is very much important. That will guide you that patient might have chances that he was implanted with multifocal IOL. So in this toric IOL, patient is having keratometry of 2.13 diopter cylinder in 96 axis, and in left 2.25 diopter cylinder at 96 axis. So I have implanted 3 diopter cylinder, because 3 diopter cylinder at intraocular lens level will correct around 2.25 diopter cylinder at corneal plane. So this is a corneal plane astigmatism, while the mentioned 3 diopter cylinder in IOL sticker is suggesting of cylinder at IOL plane. So let's see its refraction. So this patient is came down from 2.25 diopter cylinder to 0.75 and 1 diopter cylinder, and this is in uh, a limit where patient is much comfortable, because similarly the one axis is almost immetropic while the other axis is myopic. This will give benefit of good near vision, and this patient, though the unaided visual acuity is not mentioned here, the binocular unaided visual acuity is for distance 6-9 and near almost N8, and with that almost all work can be done without glasses by the patient. Yes, on addition of glasses, the clarity improves much more. The intraocular pressure is also in normal range. You can see the keratometry is still the same, 2.37 diopter at 90 degree, 2.5 diopter at 96 degree. But in on implantation of toric intraocular lens, the requirement of cylinder correction has significantly decreased. So nobody can guarantee you that it will be 0 0, but it is significantly decreased, so the dependency on the glasses will be decreased. And this is a case of slightly distorted pupil. Patient was operated for glaucoma surgery. You can see the blab at about 110 degree axis, and you can see the keratometry is also showing cylinder at 124 degree, and the refractive axis, this is left eye, and the axis is 107, and with correction you can see minus 1.5 diopter cylinder 100 degree gives 6.9 visual acuity, but the pupil is slightly large and distorted, so the visual acuity does not go to 6 by 6, but near vision definitely improves with 2.5 diopter addition to N6. But patient is having intraocular pressure 26 millimeter of mercury, so we will not give final refraction to this patient, and we will call the patient again And you can see I have done autoref on two different machine. In the first machine, it gives 1.37 diopter cylinder at 1.75 diopter axis at 105 or 107, while in the other machine it is, though I have kept plus cylinder here, the spherical maybe 1.88 2 something with 2.5 cylinder, and axis will be around 99. So there is a minor difference in two individual autoref also, depending upon the machine accuracy and the calibration. So you have to check the calibration of auto refractometer and auto keratometer every month, so that you will not have false reading, or the constantly reading with some fixed error. So this is the case where we have to control the intraocular pressure first, then again we have to do the refraction, and final refraction will be given after that. So that is all about the pseudophakic refraction clinical cases.